So we'll spend the next hour reviewing sections B, C, H, J, and O, including influenza. And again, as in all the other presentations, this is a list of the acronyms that we'll be using. In the presentation, we will identify and explain the intent of each of the sections and discuss the coding instructions and required information for Section B, hearing, speech, and vision, Section C, cognitive patterns, Section H, bladder and bowel, Section J, health conditions, falls, Section O, special treatments, procedures, and programs, influenza vaccination, and then we'll do some practice coding for these sections. At the end of the presentation, you should be able to demonstrate a working knowledge of each of these sections, as well as state the intent of them, and then apply your coding instructions to accurately code practice scenarios. So first, we'll look at Section B, hearing, speech, and vision. Specifically for Section B, our objectives today will be to describe the intent of the section, explain the revisions to item BB0800, and use the guidance to accurately code our practice questions. The intent of Section B is to document the patient's ability to understand and communicate with others. This is accomplished by collecting data in 3 sections: BB0100 Comatose, BB0700 Expression of Ideas and Wants, BB0800 Understanding Verbal Content. Section B is intended to document the patient's ability to understand and communicate with others in his or her primary language, whether in speech, writing, sign language, gestures, or a combination of these. It can be challenging to differentiate between these sections, and data needs to be collected and reported for each. In this section, we'll go into more description of the sections and provide some examples to help us with coding Section B. So we'll start with some clarifications. Between version 3.0 and 4.0 of the LTCH CARE Data Set, there are no changes with the first 2 items, B0100 Comatose and BB0700 Expression of Ideas and Wants. For Section BB0800, a clarification has been provided with the addition of understanding nonverbal content as opposed to only verbal. This is, of course, tremendously helpful with our patient populations because we have so many adaptive devices and methods for communication with our patients, and this language now allows us to capture those. While there are no changes made for B0100 Comatose, we'll offer a new coding tip and an example. This scenario applies to an admission and planned discharge assessment, and the reason for the data collection is because patients who are in a coma or a persistent vegetative state are clearly at increased risk for mobility complications as well as others. So for B0100, we will use the code 1YES for a diagnosis of coma or persistent vegetative state, which is documented in the patient's medical record. Review the medical record to determine whether a diagnosis of coma or persistent vegetative state has been documented by a physician, nurse practitioner, physician assistant, or clinical nurse specialist as allowable under your state laws. You would code 0 no if a diagnosis of coma or persistent vegetative state is not present on admission or discharge. We have some other common diagnoses that have similar symptoms but are not the same as coma or persistent vegetative state, such as some of the progressive muscular disorder, neurological disorders. And so it's very important that we have it specifically documented as coma or persistent vegetative state in the medical record. So here's a coding scenario for B0100. Mrs. M was admitted to the LTCH and is non-communicative and often sleeps. Mrs. M's medical record includes a diagnosis of Alzheimer's disease. Mrs. M's medical record does not include a diagnosis of coma or persistent vegetative state. So how should we code B0100? And you'll code 0 for no and code 1 for yes. Just a few more responses. So 95% of us chose code 0, no. And this is, of course, the correct answer. We code no if a diagnosis of coma or persistent vegetative state is not present at the time of admission or discharge. And here we often offer the rationale for how we coded this coding scenario. Because there is no documentation in the medical record that states Mrs. M's diagnosis includes coma or persistent vegetative state, no, 0 is the most appropriate response. The next section we'll review is BB0700, Expression of Ideas and Wants. This is completed on admission and planned discharge assessments, and this is what it appears to look like on the LTCH CARE Data Set. So let's try a coding scenario for BB0700. Mr. B had a stroke several weeks ago and has a diagnosis of expressive aphasia. The certified nursing assistant asks Mr. B if he wants help with bathing. He looks at the certified nursing assistant and smiles, but does not respond verbally. The certified nursing assistant reports to the nurse that she has not been able to determine Mr. B's preference and needs help with any of his activities of daily living, since he was admitted the day before. The nurse interacts with Mr. B and determines that he rarely expresses himself. The nurse plans to collaborate with the speech-language pathologist and other team members and Mr. B to increase Mr. B's ability to express himself. How would you code BB0700? And our choices for BB0700 include coding 4, express complex messages without difficulty and with speech that is clear and easy to understand. Code 3, exhibit some difficulty with expressing needs and ideas, or speech is not clear. Code 2 frequently exhibits difficulty with expressing needs and ideas, or Code 1 rarely never expresses self or speech and is very difficult to understand. Okay, so let's see how we did. 96% of you chose D, which is code 1, rarely never expresses self or speech and is really very difficult to understand. And that is, of course, the correct answer. And the reason that we would choose this in the scenario is that due to Mr. B's expressive aphasia, he's unable to verbally express his needs, and that was indicated by both the CNA as well as the nurse. Okay, so BB0800 is our next section, understanding verbal, and now in addition, nonverbal content. This section is completed for admission and planned discharge as well. As mentioned, any inability to understand a person-to-person communication can impact our patients' well-being, including their association with other people and their ability to follow their health and safety instructions. So here's a coding scenario for BB0800. Mr. T sustained an acquired brain injury and is on an invasive mechanical ventilator. Mr. T uses electronic communication device to respond to staff and family questions. Staff members report that he only understands basic conversation. The staff needs to simplify all communication for him to understand what is being asked. The family reports that simple and short messages are necessary during their conversation to elicit accurate responses. So how would we code BB0800 in this scenario? And our options are coding 4, understands, code 3, usually understands, code 2, sometimes understands, or code 1, rarely never understands. So on this one, we had 60% choose B, usually understands, and 36% choose C, code 2, sometimes understands. So our correct answer is C, sometimes understands. So let's go through our rationale for why we would pick code 2. In this situation, Mr. T uses his electronic device to indicate his understanding of only basic conversations or simple direct phrases. He's really understanding only the most basic conversations and direct phrases that are directed to him. Okay, and here's another coding scenario for BB0800. Mrs. K is recovering from the surgical removal of a cancerous brain tumor and has severe hearing loss and some cognitive limitations. The staff, patient, and family use an electronic device to communicate with her. Staff members and family reports that Mrs. K, on a few occasions, required visual cues to understand what is typed into her electronic device in order for her to respond accurately to questions. Mrs. K can understand most conversations with the use of her electronic device. How would you code BB0800? And for this, we would choose from code 4, understands, code 3, usually understands, code 2, sometimes understands, and code 1, rarely or never understands. Okay, it looks like everybody has made a selection. So 92% chose the correct answer, which is code 3, usually understands. So let's go through our reasoning for that selection. 3 usually understands. The patient, in this scenario, the patient understands most conversations, but misses some part or some intent of the message and requires some cues at times. Mrs. K and her family use the electronic device to communicate, and she's understanding most of the communication with some cues, which makes 3 usually understands the most appropriate selection for her scenario. So just summarizing section B, section B has not changed. There does exist one clarification for BB0800 to include nonverbal content in addition to verbal content, but otherwise the section is unchanged. The next section will be section C, cognitive patterns. So in this section, we're going to define section C and explain its intent and rationale. We'll discuss coding instructions and required information for the items, and we'll apply the coding instructions to accurately code practice scenarios. Section C is intended to determine if a patient has the signs and symptoms of delirium using the Standardized Confusion Assessment Method, or CAM. The section on the LTCH CARE Data Set has a shortened version of the CAM to guide the user to complete all requirements. It includes A through E for completion, with yes/no responses required for each. There are some subtleties to be aware of in section C. Delirium is often misdiagnosed as dementia, or it can be. However, patients who truly have dementia can also experience delirium. A recent deterioration in a cognitive function of a patient may indicate delirium, which may be reversible if detected and treated. Delirium can be a symptom of an acute treatable illness, such as in the case of a urinary tract infection or an adverse reaction to medication, and therefore detecting delirium in a timely manner can help clinicians determine acute changes in condition that can then be treated and by eliminating the source. So it's important to understand the definitions in section C. Delirium is defined as a mental disturbance characterized by new or acutely worsened confusion, disorganized expression of thoughts, change in level of consciousness, or hallucinations. Fluctuation is defined as the behavior that tends to come and go and or increase or decrease in severity. The behavior may fluctuate over the course of an interview, discussion, or the assessment period. Fluctuating behavior may be noted by staff or family or documented in the medical record. We also need to understand the definition of inattention. Reduced ability to maintain attention to external stimuli and to appropriately shift attention to new external stimuli. Patient seems unaware or out of touch with the environment, dazed, fixated, or darting attention. Disorganized thinking is evidenced by rambling, irrelevant, and/or incoherent speech. So as we move into the first item here, C1610A and C1610B, we're asked to assess for acute changes in mental status and find evidence of acute changes through a variety of methods, including our patient interactions, medical record, reports from family or caregivers, and then staff reports as well. So here is section C1610A on the LTCH CARE Data Set. We would code either 0, no, if we're unable to find evidence of any acute changes in mental status from the patient's baseline, or we would code 1, yes, if we find evidence of an acute change. This coding is required for admissions, planned and unplanned discharges. And then for C1610B, we also have the option of coding 0, no, if the abnormal behavior did not fluctuate during the day, did not tend to come or go or increase or decrease in severity. And we would code 1, yes, if the abnormal behavior fluctuated during the day and it came and went or increased or decreased with severity. And here we're trying to answer, did the abnormal behavior fluctuate during the day, that is, tend to come and or go, increase or decrease in severity? And then C1610C, we're also asking here to make a distinction between attention and level of consciousness. Inattention is evidenced by patient, clinician records and interactions, medical records, reports from families and significant others, staff reports. Another method that is used for identifying inattention quite simply is to have the patient count backward from 20, and if unsuccessful, they may not have a strong attention. C1610C, we have the options of coding 0, no, if the patient remains focused and was not easily distracted or having difficulty keeping track of what was said. And we would code 1, yes, if the patient had difficulty focusing or was easily distractible or was having difficulty keeping track of what was said. And again, like the other sections for C1610D, disorganized thinking, we use the same steps for assessment, utilizing patient interview, medical record, reports from family and significant others, and staff reports. And for the coding of D, disorganized thinking, we also have code 0 for no if the patient's thinking was disorganized and was organized and coherent, even if the answers were inaccurate or wrong. And code 1, yes, if the patient's thinking was disorganized or incoherent, such as rambling or irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject. And C1610E1 and C1610E2, altered level of consciousness, we're utilizing the same methods for assessing, the same steps for assessing this section as the ones prior. Patient and clinician interactions, medical record, reports from family, and staff reports. And here on the LTCH CARE Data Set, we see altered level of consciousness with the option to code 0, no, if the patient was not alert, and code 1, yes, if the patient was alert. This assessment is required on admission, planned and unplanned discharge. C1610E2 is asking us to qualify the altered level of consciousness, and we code 0 no if the patient did not exhibit any of the following: vigilant hyper alert, which is the patient being easily startled to any sound or touch, his or her eyes are wide open. If they do not exhibit lethargy, drowsy, and they're easily aroused. Patient repeatedly dozes off while you're asking questions and may be difficult to keep the patient awake for the interview. The next item you would want to consider is stupor, difficult to arouse. The patient is very difficult to arouse and to keep aroused for the interview, requiring shaking and or repeated shouting, hopefully gently. And then coma, unarousable. The patient cannot be aroused despite shaking or shouting. So in this scenario, we would then code 1 yes if the patient did exhibit any of those items. So we're coding no if they are not exhibiting any of those signs and symptoms, and coding yes if they do. So let's try some coding scenarios now for C1610D. Mrs. B was admitted to the LTAC with a tracheostomy in place and was receiving invasive mechanical ventilation. There are no plans for active weaning due to a current respiratory infection. Mrs. B is alert and oriented. Mrs. B's thinking is organized and coherent. She communicates effectively using a letterboard and by writing notes. How would we code C1610D? And we have the options of coding 0 no, coding 1 yes, entering a dash, or leaving the item blank. And we're trying to answer the question, was the patient's thinking disorganized or incoherent, such as rambling or irrelevant conversation, or unclear, illogical flow? So 100% of us said code 0 no, and that is correct. And so we coded this way because Mrs. B's thinking is organized and coherent, and she's alert and oriented and communicates effectively using her letterboard and by writing notes. The clinicians are able to determine this by using the identified communication strategies and by observing the patient's interactions with others. Additional sources to validate the patient's status during the 3-day assessment period are the medical record, the family, and staff, as mentioned for all of the sections. So in summary, Section C has not changed. Section C is utilized to determine if the patient has signs and symptoms of delirium. The reason this section is so important is because sometimes delirium is unrecognized and undocumented, but we know that early recognition and treatment can result in improved outcomes for the patient. Now we'll move on to Section H, bladder and bowel. Our objectives for this section are to define Section H, bladder and bowel, explain the intent and rationale of the section, discuss the coding instructions and required information, and then apply those coding instructions to practice scenarios. So Section H is intended to gather bladder and bowel continence because bladder and bowel continence can have a number of negative impacts on the patient, including increased length of stay, skin breakdown, rashes, and wound worsening, increased falls as the patient makes attempts to get out of bed unassisted for the bathroom, and social embarrassment and isolation. It can sometimes be addressed or minimized by treating the underlying condition, and so again, it's very important to address and recognize bladder and bowel incontinence. There are some important definitions for Section H. Continence is the ability to voluntarily release urine or stool in a commode, toilet, or bedpan. And incontinence is the involuntary passage of urine or stool. Section H0350 on the LTCH CARE Data Set is where we have bladder continence. We code one of the provided options on the admission and planned discharge assessments. And our options are always continent, stress incontinence only, incontinent less than daily, incontinent daily, always incontinent, no urine output, or not applicable. To gather information for section H0350, we want to review the medical record, including flow sheets, nursing assessments, progress notes, HMPs, but also family input and caregiver and staff information. One reason that the flow sheets are so helpful is that we code according to the amount and the number of episodes of incontinence that occurred during the assessment period, and that's typically found in our flow sheet documentation. Code 0, always incontinent, if throughout the 3-day assessment period, the patient was continent of urine without any episodes of incontinence. Code 1, stress incontinence only, if during the 3-day assessment period, the patient had episodes of incontinence only associated with physical movement or activity such as coughing, sneezing, laughing, lifting, heavy objects, or exercise. Code 2, incontinence less than daily, if during the 3-day assessment period, the patient was incontinent of urine once or twice. Code 3, incontinent daily, if during the 3-day assessment period, the patient was incontinent of urine at least once daily. Code 4, always incontinent, if during the 3-day assessment period, the patient had no continent voids. Code 5, no urine output, if during the 3-day assessment period, the patient had no urine output, such as in a patient with renal failure or chronic dialysis, for the entire 3 days. And Code 9, not applicable if during the 3-day assessment period, the patient had an indwelling bladder catheter, condom catheter, or ostomy for the entire 3 days. We often get questions about stress incontinence and how this is defined and how it's applicable in Section H. So stress incontinence really is referring to episodes of small amount of urine leakage only associated with physical movement or activity, such as I mentioned coughing, sneezing, laughing, lifting objects, or exercise. And this is an important distinction that it's a small amount of urine leakage and it's a result of one of these exercises. Also, incontinence is the same as leakage. They're viewed one and the same for your assessment. As mentioned, we have to get the documentation to determine the frequency. And also, if intermittent catheterization is used to drain the bladder, you code the incontinence level based on the continence between the catheterizations. So if the patient is otherwise continent, then you would code continent as such. H0400 is for bowel continence, and it's applied only on admission. H0400 is also assessed using the same steps for assessment, reviewing the medical record, bowel incontinence flow sheets, nursing assessments and progress notes, history and physical, interview with family and patients, and the direct care staff. So for coding 0400, bowel continence, we want to code 0 for always continent if during the 3-day assessment period the patient was continent for all bowel movements without any episode of incontinence. We're coding 0 occasionally incontinent if during the 3-day assessment period the patient was incontinent for a bowel movement. This includes incontinence for any amount of stool at any time. Code 2, frequently incontinent if during the 3-day assessment period the patient was incontinent for bowel movements at least twice, but also had at least one continent bowel movement. And this includes continence of any amount of stool as well. Code 3, always incontinent if during the 3-day assessment period the patient was incontinent for all bowel movements and had no continent bowel movements during the period. Code 9, not rated if during the 3-day assessment period the patient had an ostomy or other device or the patient did not have any bowel movements during the 3 days. Note that any patient who doesn't have a bowel movement for 3 days should of course be evaluated for constipation. So here are some coding tips for H0400. They address some of our common stumbling blocks in the LTAC environment. Being continent has to do with the ability to voluntarily release stool on a commode, toilet, or bedpan or as a result of a planned bowel movement as part of a bowel program. If the patient cannot voluntarily control the passage of stool, which results in involuntary passage of stool, then he or she is considered incontinent. Patients who require assistance to maintain the passage of stool via artificial initiation, like manual stimulation or rectal suppositories or enemas, would be considered continent of their bowel as long as the result of releasing the stool was in a commode, toilet, or bedpan. And bowel incontinence precipitated by loose stool or diarrhea from any cause, including laxatives, would count as incontinence. So let's try a coding scenario for H0350. Here's a coding scenario for bladder continence. Mrs. B has a history of stress incontinence. During her 3-day assessment, she experienced a large amount of urine leakage daily. How would we code H0350? We really want to remember our definition of stress incontinence for this one. So A, we would code 1, stress incontinence only. B, code 2, incontinent less than daily. Code 3, incontinent daily, or code 4, always incontinent. Okay, it looks like all of our responses are in. 77% chose code 3, incontinent daily, and we'll review why this is the correct answer. So in Mrs. B's case, she is incontinent daily because of large amounts of leakage, and that's considered incontinence. So if we were referring to her diagnosis of stress incontinence, it would be a small amount of leakage. Although she does have the history of stress incontinence, this is categorized by the small amounts, and it must be associated with a physical movement or activity and exercise. So in Mrs. B's case, because it's large and it's not related to one of those activities, although she has the diagnosis, it would not be considered stress incontinence and would rather be considered incontinent daily. So in summary, Section H has not changed, and it gathers our urinary and bowel incontinence details. Patients with intermittent catheterization should be coded based on their level of continence between catheterizations. And information can be gathered from the record, interviews with patients, families, and direct caregivers for all of the items in the section. Section J, health conditions, falls. So the objectives for the section are to define Section J, health conditions, explain the intent and rationale of Section J, discuss coding instructions and required information for the items, and then apply the coding instructions to accurately code a practice scenario. The intent of Section J is to collect falls since admission and any injury caused by the fall. However, only falls with major injury, which are entered into Section J1900C, are used in the calculation of the quality measure, application of percent of residents experienced one or more falls with major injury is how it reads, and it's based on NQF number 0674. The rationale for collecting data in Section 1800 is that falls are a leading cause of morbidity and mortality among LTCH patients, and the fear of falling can limit an individual's activity and negatively impact their quality of life as well as their progress in the medical setting. There are some very important definitions associated with Section J. A fall has a very specific definition, and it's defined by an unintentional change in position, coming to rest on the ground floor or onto the next lower surface, for example, onto the bed or chair or beside a mat beside the bed. It may be witnessed, reported by the patient or an observer, or identified when a patient is found on the floor or the ground. And it cannot be the result of an overwhelming external force. So for example, if one patient pushes another patient, we would not consider this a fall in section J. An intercepted fall occurs when the patient would have fallen if he or she had not caught him or herself or had not been intercepted by another person. And an intercepted fall is considered a fall in the LTCH setting. The Centers for Medicare and Medicaid Services understand that challenging a patient's balance and training him or her to recover from a loss of balance is an intentional therapeutic intervention and does not consider anticipated losses of balance that occur during supervised therapeutic interventions as intercepted falls. So we often hear from our therapists that they're challenging the patient, and that in the setting for section J would not be considered an intercepted fall. Here's some additional definitions that help us to sort through the terms of injury, major injury, and injury except major. So injury related to a fall is any documented injury that occurred as a result or was recognized within a short period of time, like a few hours, after the fall and attributed to the fall. So we know sometimes it's difficult to attribute the injury directly to the fall in the moments right after, and sometimes things will pop up, in the next couple of hours or after assessment. So that injury would be relatable in this section. Major injury includes bone fractures, joint dislocations, closed head injuries with altered consciousness, and subdural hematomas. An injury except major includes skin tears, abrasions, lacerations, superficial bruises, hematomas, and sprains, or any fall-related injury that caused the patient to complain of pain. To gather this information, you want to review the LTCH medical record, but also you can utilize physician nursing therapy and nursing assistant notes, incident reports, fall logs, whatever method you utilize in your environment to capture falls. On the planned discharge, unplanned discharge, and expired assessments, you will be asked to complete this question. Has the patient had any falls since admission? And then a follow-up question to J1900 asks us to document the number of falls by injury type. So we do need to fill out each one of these boxes and code 0, none, 1 for 1, or 2 for 2 or more. So we want to determine the number of falls that occurred since admission and then code their related level of injury. Code each fall only one time. So if a patient has multiple injuries and a single fall, you want to code the highest level of injury. So section J1900A, we have some coding for each of the sections here. So we have code 0, none, if the patient had no injurious falls since admission. Code 1 if the patient had 1 non-injurious fall since admission, and then code 2 if the patient had 2 or more non-injurious falls since admission. And then similarly for J1900B, we would also want to code this section independently. So we want to code 0, none if the patient had no injurious falls except major. We want to code 1, if the patient had 1 injurious falls except major since admission. And then we want to code 2 or more if the patient had 2 or more injurious falls except major since admission. And then finally, J1900C is where we're coding our major injuries. So here, if the patient had a major injurious fall, we want to code, had no major injurious falls since admission, we want to code 0, none. We want to code 1, if the patient had 1 major injurious fall since admission, and 2 for 2 or more injurious falls since admission. So let's try a couple coding scenarios for J1800. Mrs. K is transferred from the LTCH to the acute care hospital for a radiology exam. During the course of the exam, Mrs. K sustains a fall and fractures her right arm. She is treated at the acute care hospital and requires an overnight stay, but then subsequently returns to the LTCH the following day. How do we code J1800? Has the patient had any falls since admission? So we have code 0, no, code 1, 1 for yes, and then code dash if you think that that's appropriate. So 100% of us said code 1 yes, which is great. It means we understand program interruptions as well. And the rationale for that is that since the patient returned to the LTAC from an acute care hospital after a stay lasting less than 3 days, the patient was on a program interruption. And therefore, we would report it as just as if it had happened in our setting. The information on the fall that occurred from the acute care hospital, provided that we're made aware of it, and in this case the injury is so significant that of course we would be captured on the planned discharge, unplanned discharge, and expired assessment when the patient is discharged from the LTAC. This is an instance where both the fall in the LTAC and the acute hospital would have to be recorded, so it would be recorded in both settings. So here's another coding scenario for J1800 and J1900. A patient reports to his nurse that while transferring to the bathroom, he fell backward and hit his head on the toilet. An X-ray revealed a spinal fracture. I don't know about you guys, but some of these are my worst nightmare, but in any case. So how do we want to code, has the patient had any falls since admission? We can code 0 for no, code 1 for yes, or entering a dash if we think that that is appropriate. Okay, looks like we're all finished. So 92% of us said code 1 yes, and that is the correct answer. So let's go through the rationale and why we would code yes in this scenario. Oh, we have to wait a minute because we got to answer the next one first. So for J1900, using the same scenario, the number of falls since admission, how would we code J1900A, no injury, as 1, J1900B, injury except major, as 2 or more, code J1900C as major injury 1. So 100% of us said code C, J1900C, major injury 1, and that is the correct answer. And so just in case we were wondering how we got to that answer, here's a summary of J1800 and 1900. We would code J1800 any falls since admission as 1, as we had indicated. Our falls with no injury as 0, because although we had a fall, the fall was a major injury. We would code falls with injury except major as 0. Patient did not have any other falls with any more minor injuries. And then falls with major injury as 1 because of the spinal fracture. So in summary, Section J has not changed. Section J for the LTACs captures any falls and injuries from the time of admission, including those which occur during program interruptions. Section J is completed on planned, unplanned, and expired discharges. Moving on to Section O, special treatments, procedures, and programs, including influenza vaccination. At the end of the section review, you'll be able to identify the time period beginning and end for the influenza season and the influenza vaccination season. You'll be able to distinguish the relationship between the influenza season and the influenza vaccination season on the LTCH CARE Data Set, and then apply the coding instructions to accurately code these data elements. So the rationale for O0250 really centers around the fact that individuals, especially older adults and those with health conditions, are at increased risk for complications when they are infected with influenza. At an institution such as an LTAC, an influenza A outbreak can lead to up to 60% of the population falling ill and 25% suffering severe complications. Mortality results from influenza-associated illnesses, such as pneumonia, and patients that are common in the LTAC environment with chronic immunocompromised disease, can be exacerbated by influenza. So let's first review the influenza season. Beginning on July 1st of the current year, and then it ends June 30th of the following year, so using our current influenza season, 2017 to 2018 influenza season begins July 1st of 2017 and ends on June 30th of 2018. This should be distinguished from the influenza from the influenza vaccination season, which begins October 1st of the current year, or when the influenza vaccine becomes available if your facility does not receive your vaccination by October 1st, but it's whichever one comes first, and ends March 31st of the following year. So for 2017-2018, our influenza vaccination season began on October 1st of 2017 and ends on March 31st of 2018. So although the vaccination season is defined specifically, as we just reviewed, LTAC should document year-round, including when a patient has been vaccinated outside of the influenza vaccination season. If the influenza vaccination was administered to a patient for the current influenza season at the time of or prior to admission, then that information would be reflected on the patient's discharge assessment. For the quality measure, only the records of patients in the LTAC 1 or more days during the influenza vaccination season, at least one day between October 1st and March 31st, are included in the calculation. Here's how Section O appears on the LTCH CARE Data Set. It appears on admission, planned discharge, unplanned discharge, and expired assessment. Section O asks for documentation of three aspects of the administration of the vaccine. O0250A asks whether a vaccine for the current influenza season was administered in the facility. O0250B asks for the date the patient received the vaccination if it was administered in the facility. And O0250C gives the reason the patient did not receive the vaccination if it was not received in the facility. So to code section 0250A, we have several options. Code 0, no, if the patient did not receive the influenza vaccine in the facility during this year's influenza vaccination season. And then if that was the case, you would proceed to O0250C to give the reason that it was not received. However, we would code 1 yes if the patient received the influenza vaccine in the facility during this year's influenza vaccination season, and then we would go on to code O0250B and give the date of the vaccination. To code O0250B, we enter the date that the vaccine was received by the patient in your LTAC, and it is important not to leave any boxes blank. So just like the other sections that we've reviewed, you want to add a 0 into the box if there's not another digit that should be placed there. For example, October 6th of 2017 should be entered as 10-06-2017. A full 8-character date is required, and if the date is unknown or the information is not available, you would need to use a single dash in the first box. For section O0250C, we have several coding options as well. Here we would code 1, patient not in facility during the year's influenza vaccination season, if the patient was, of course, not in the facility during that time frame. We would code 2, received outside of this facility if the patient received an influenza vaccination in another setting during this year's influenza vaccination season. We code 3, not eligible if the patient has a medical contraindication, if the influenza vaccination was not received because of the contraindication or precautions. This could include allergic reactions to eggs or other vaccine components. It can include a previous reaction or a physician order not to immunize, history of Guillain-Barré syndrome within 6 weeks of the previous influenza vaccination. However, the patient should be vaccinated if the contraindications or the precautions end for some reason. We also can code 4, offered and declined, if the patient or responsible party or legal guardian has been informed of what is being offered and chooses not to accept the influenza vaccination. We can code 5, not offered, if the patient or responsible party or legal guardian was not offered the influenza vaccine. Code 6, inability to obtain vaccine due to a declared shortage if the influenza vaccine was unavailable at the facility due to a declared vaccine shortage. However, the patient should be vaccinated once the facility receives the vaccine, and the annual supply of inactivated influenza vaccine and the timing of its distribution cannot be guaranteed in any year. Code 9, none of the above if none of the listed reasons describe why the influenza vaccine was not administered. This code is also used if the answer is unknown. So let's do a practice scenario for coding B0250. Mrs. J received the influenza vaccine in the LTCH during this year's influenza vaccination season on October 2nd of 2017. So how would you code B0250, and what is your rationale? So this is not a polling question. So here we can go through B0250A. So A would be coded as 1 yes, because we know that she did receive the vaccination. B0250B would be coded as 10-02-2017. And then we would skip B0250C because there's no reason that she did not receive the vaccination. She did receive the vaccination. Okay, let's try another one. B0250 coding scenario number 2 has Mrs. T receiving the influenza vaccination at her doctor's office during this year's influenza vaccination season. Her doctor provided documentation of Mrs. T's receipt of the vaccine to the LTCH to place in Mrs. T's medical record. He also provided documentation that Mrs. T was explained the benefits and risks of the vaccine prior to administration. So how would you code B0250, and what is your rationale? If you can think through A, B, and C. So in this scenario, B0250A would be coded 0, no, because she did not receive the vaccination in the LTCH. We would then code B0250B by skipping that section, so it's not coded. And B0250C would be coded as 2, received outside of this facility. She did receive it at her doctor's office, and it was during this year's influenza vaccination season. We have another coding scenario for B0250. Mr. N was offered the influenza vaccine during his LTCH hospitalization beginning in February of 2017. Mr. N refused the influenza vaccine, asserting it always gave him the flu when he received it in the past. There's something we've never heard before, right? How would you code B0250, and what is your rationale? So in this coding scenario, we would code B0250A as 0, no, it was not received in the facility. We would skip B0250B, and then we would move on to B0250C, and we would code it as 4, offered and declined. as we did make the offer, but he refused it, and we should have good documentation of those refusals as well. So in summary, Section O is a very important section for our patients who are at serious risk. Patients that are infected with influenza are at a higher risk for complications, and it's more likely that they require a higher level of care and hospitalization. CDC does recommend an annual influenza vaccination, especially for at-risk populations. And then overall, a summary of all of the sections that we've reviewed today. We went through section C, H, J for falls, and O, influenza vaccination. None of those have changed, and we did add one clarification to section B to include the nonverbal communication. So we want to make sure that we communicate what we have learned today or realized today through action planning back at our facilities. So take the time to review the intent, rationale, and the steps for assessment for all of the sections with your teams. You'll likely get a better outcome and better documentation if people understand these aspects. Review the language clarification that was made in section B and its implication, making sure that everyone understands we can now account for nonverbal communication. Review the key dates related to the influenza vaccination season, being that we're right in the middle of it at this point. It's very important that everyone is aware and offering vaccination to our patients. And practice coding a variety of scenarios with the staff. There are scenarios that are located in the QRP manual if you're looking for some to go through with your staff and help them to practice coding scenarios as well. I have about a minute and a half, and we covered a lot of content. I don't know if anyone has any questions at this point, or if you're all ready for lunch. It's okay, you can ask them if you need. Mm-hmm. Could you please come to the microphone, if you wouldn't mind?
I'm Sheila Brady, and I'm from Baptist Health Extended Care. In item 1610B, when talking about the abnormal behavior fluctuating during the day, is that day considered a 24-hour period or just during daylight time?
Would anyone like to clarify that? The question was, when we're referencing day for the fluctuating behavior, are we referencing the daytime hours or the 24-hour day as a whole? We'll pause for a moment. Good question.
24 hours?
So it's confirmed
Thank
it's
you.
24-hour period. Great question. Thank you for clarifying. Any others? Thank you for your time.